So before we get started clotting it, hello. Who else? Brooke. Hi. See, my dad, he was said you were injected with a phonograph needle. It's okay. Phonograph. Records, they had records. So I was like you. I'm constantly having to say something. Here we go. So I told you I was going to get this for you, and I did. It's no big secret. So I mean, here's the white count. So that's typical. I mean, these are called absolute. This is what the labs use now because there's subtle variations, and they're looking for a range. So the neutrophils fall into this range that's here. Lymphocytes, even though it appears to be on the low side, that's normal. Monocytes right at the edge of high. Again, so there's a certain amount of plus. You can see there's a certain amount of plus or minus. Eosinophils, basophils, and this is what. And if those are irregular, then you look at the white count. The white count's normal, so I mean, you're not. It's unlikely that there's anything significant going on with tiny irregularities. Okay, now my red count's low, but look at the hemoglobin. So it's just on the bottom line, but between you and I, men typically 14 to 17 is about right. So this takes men and women into account. And I told you I run low. And these, not that you have to, here's the hematocrit. You can see it's on the low end. So, I mean, I'm borderline anemic. This is interesting because that's why they thought it was probably B12 related because of, and we used to do B12 levels. These are called the Wintrobe indices. Fancy name you don't have to know anything about now. It says mean MCV means mean corpuscular volume. In other words, the volume and the corpuscle is another name for the red cell. So that's big. There's borderline too big. That's why, remember, they get smaller as they mature. So this is a mature problem, and that's where B12 probably comes in. And what it does, but fortunately, the overall amount, the concentration's okay. Here you can see the platelets fine. Just to give you a quick snapshot. And so, I mean, these aren't all the things. I mean, I looked through them this morning. Let's see. I mean, this is from a year ago. I haven't had a fresh set in a year. So if we look over here, and you can see this is typically doctors will do all this here. You know, that's the hemoglobin A1C. You routinely do that. I mean, I have a family history of diabetes. You know, you can see that's real good. That's where, I mean, then you're not even suggesting it. But if you want to look at the, let me get back to the test results. I went too fast. Then you will look at something like this typical basic metabolic panel. And unfortunately, everything was normal when I had this done a year ago. This is they check your electrolytes. Okay, all of those. These are measures for kidney, urea, nitrogen. I had this test on fasting, so this was a fasting blood glucose. You could do it random, perfectly normal. So creatinine and blood urea nitrogen we call BUN, and creatinine, both those are your measures of kidney function right away. Boom. And those things that you look out for. Then you have the calcium that's there, bilirubin we had talked about, proteins, fractionates them a little bit. Here's just albumin, which is again the most important. They create certain ratios. This is interesting. When you get to kidney, you're going to see that osmolality is the basic solute to solvent thing, and around 300 is normal. That, I mean, when we get to kidney down the road, you'll see that. And what they do now is they call this. They are from these numbers. They're able to estimate what they call GFR, which stands for glomerular, I beg your pardon, filtration rate. And that's just an overall measure of kidney function. Okay, your actual rate would be higher than that. But by this method, as long as you're in this number, there's no suggestion that your kidneys are a problem. And again, it's much more relevant to folks as they get older than to you, healthy young people. Just saying. Okay, it gives you a quick snapshot into what we look for. I mean, and all these different tests are things that you just go through over time. So that's sort of the introductory nugget. Now we'll get back to what we're doing. Okay, this is where we left off. So this is sort of clotting This is much more relevant, not to a big injury. This is if you got a little cut or a scratch, this would apply. Typically, most of this clotting information that you're seeing here refers to interior. Like I was telling you, all those blood vessels, all those passageways, any of the ones that aren't capillaries, the tiny ones that are arterioles, they're like roadways and they're constantly needing to be repaired. Okay, when you have a larger injury, this doesn't really apply so much. If had a bad accident and all of a sudden you're like this because you're going to need stitches. You've seen a wound like that, and you'll certainly see more of them. It doesn't apply so quickly. The bleeding doesn't stop so easily. So it's a matter of degree. So hemostasis, stopping bleeding. Okay, a very rapid series of reactions to stop bleeding, and they involve clotting factors that we'll get to somewhat generically. And so what happens on the vessel that's injured or vessels that are injured, the minute there's an injury, they release chemicals that induce them to spasm. It's self-protective. Oh, we're hurt. Let's not let any more blood out of the system. Okay. Then platelets are activated by the tissues that are exposed, principally collagen. Remember, what's the most abundant of all our connective tissue proteins? Collagen. When platelets are exposed to collagen, they start to aggregate. They clump together, and that's going to start the clotting process. And then, so they form a plug, and then eventually they form a clot, sufficient size. So initially, the spasm is injury to the smooth muscle. And again, that's arterioles, venules. You'll see this when you get into both lab and here in lecture when we start talking about sort of the cross-sectional anatomy of blood vessels. The chemicals, the lining cells, those are called endothelial cells. They're simple squamous lining cells. They release them, and as the platelets begin to slam together, they start to release more chemicals themselves. All those little granules are chemicals. And pain reflexes play a role, much more significant in small blood vessels. If somebody gets like a bad cut here and all of a sudden that blood's gushing out, this is not going to stop it. But if you see that happening, the best thing you can do is remember, with few exceptions, pressure stops all bleeding. Get your hand on it, get something on it, get a towel on it, doesn't matter, whatever you have handy, and push hard on it, whether it's on you or somebody else, and hold it. If it's a vein, and we're talking about when we say by the clock, if I say to you, hold it in place for 5 minutes by the clock, you hold it. Don't look at a watch or a stopwatch, and think to yourself, this must be about 5 minutes. When you take your hand off, it'll be about 2 minutes. Time runs slowly when you're doing things like that. So that's the kind of thing where you want to get an actual clock on it, because typically you should be looking at 5 minutes, maybe 10 minutes of holding pressure. That's what they say about pressure stops bleeding. Unless you have a massive bleed, then you better be holding them and waiting for an ambulance or getting a tourniquet on or racing them to the emergency room, because now you got trouble. Okay, significantly reduce blood flow until other mechanisms can kick in. Collagen fibers are exposed. There's collagen everywhere. Okay, what happens is these are substances. Nitric oxide, we talked a little bit about when we talked about neurotransmitters. Blood lining cells and blood vessels make it. They stop platelets from sticking. This is a form of a prostaglandin, a local signaling chemical. All of that's part of it. And as long as the walls are intact and I do this 1,000 times. I mean, this is the lining of a blood vessel. This is the lining inside your heart. It's smooth. So I can roll something like that. As long as there's no obstacle, it just rolls. It's supposed to be like that. That's the whole idea of these simple squamous epithelia, smooth lining. If there's something in the way and it stops at a bump, an irregularity, that's going to start the process of clotting. Anything that gets in the way. It creates turbulence. And turbulence starts to make platelets and red blood cells and a variety of elements start to slam together. Now you get a problem. And particularly if it's undesirable. This is one of the factors that, and my first wife had this, is one of the reasons you remember me telling you an endocrine why she had to get injections of the antidiuretic hormone that we make in the lab because it has some impact on clotting factors. She had a variant of von Willebrand's disease. It's a platelet. There's a variety of genetically related platelet problems. She never had trouble with back when we were together, when she was very healthy, with anything, with a cut stopping bleeding. But this happened during surgery. She was having a surgery, an ovarian surgery, trying to they call it wedging the ovaries, trying to manipulate them to facilitate ovulation when we were trying to have children biologically. Not that that worked, but she ended up with a significant amount of bleeding internally, and she had to get 2 transfusions. This is 1981, back a long time. And some of that was pursuant to what we were talking about for those in micro. That's one of the things that why she may have been exposed to hepatitis C there in early days. I'll get into that today. So here's von Willebrand's factors. So that's something that is more common than you think, and it's not. That's why taking a history is very important. Because people will, if they don't know about that, because normal tests for bleeding don't include testing for von Willebrand's factor. Okay, so those platelets, when they come together, they get sticky, they release more chemicals. Here's another neurotransmitter, but in the bloodstream. It actually helps blood clots, serotonin. This is another, this thromboxane A2. This is another prostaglandin agent. So, and this, as we've commented on before, is a positive feedback. The more platelets stick, the more chemicals, cause more platelets, etc. And it will continue to do this until the clot forms. That's the idea of positive feedback. The end of the event, in this case, the termination of that feedback loop is when the clot forms completely. And small vessels, not so good. Big vessels, important. So eventually, that platelet plug is reinforced. Because what happens, eventually those platelets will lead to fibrinogen becoming fibrin, and it's much more in larger vessels that you're going to see this process. And typically when larger vessels are damaged, it involves what you're going to see is called the extrinsic pathway. When we say intrinsic, it means factors are already in the bloodstream. Extrinsic indicates that tissue's been damaged, and that releases a factor into the bloodstream and into the area that causes the clotting to happen, and happen rapidly. Because if tissue's damaged, now that's a bigger problem than just doing roadway repair. I mean, it's like, I got a little knock on my driveway here, we'll patch it up and coat it. That's basically the intrinsic pathway. Sort of like what PennDOT doesn't do continuously. Just go to another state and see the roads. Oh, we're not in Pennsylvania. Don't get me started. So the clotting factors, we call them procoagulants because most of them are in the inactive stage, and the whole ball game is activating them. We number them 1 to 13, Roman numerals. You don't have to remember what this or what that one is. Okay, vitamin K, very significant. Okay, so that's what I remember. K for clotting. Right? Works for me. I'm helping you with these things. You should be, right? That would be easy to remember. Addie remembers it already. Okay, and they're just showing you some illustrations of it. So look at this and blah, 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 blah. Here we go. Here are the 2 pathways. So the extrinsic pathway hopefully happens very infrequently because it's involved in really damaged tissue. Okay, the intrinsic pathway happens all the time. The extrinsic one, because of the damage, is very rapid. What you're going to see is a short trip. They're both going to the same area. You're going to see basically one involves a series of multiple steps leading eventually to something called factor 10, and the other one, boom, boom, you're there. So the extrinsic pathway, rapid. A couple of steps get you to a common endpoint we call factor 10, and this one involves a longer series. And again, just like anything else, short versus long. This happens all the time. Hopefully this happens very rarely. Each pathway cascades towards the end and eventually activates factor 10. So most of these, again, the term pro means precursor or inactive. If these were active before then you would have a significant disorder where you're clotting excessively. And it's either way. If you don't clot sufficiently or you clot excessively, it's a big problem. It's only going to cause grief. I mean, it's just the nature of it is. So factor 10, and you're going to see calcium plays a role with this. There's an additional factor that's there. There's another factor here. And what that does is it activates something called prothrombin. So here's, in a nutshell, the whole idea of activating this factor 10. Effectively, the whole ball game, as you will see better than and looking on the board, will be better than me writing it on the board. The whole idea is we're going to change this magical chemical by making what they show there called prothrombin activator. Activating this so-called activator. What it is effectively it's an enzyme. It's going to change prothrombin to something called thrombin from its inactive or pro form to that, and that thrombin is going to be the catalyst or enzyme that's going to change the dissolved fibers in your bloodstream, fibrinogen to fibrin. That's really what the whole idea of the clotting cascade is, to eventually get to the point where we're going to activate prothrombin into an active chemical called thrombin, and that thrombin is going to act as the catalyst to make fibrinogen to fibrin. You're going to see this repetitively with all of these steps. So the intrinsic pathway is intrinsic because they're in the blood. Things can trigger it. Typically, if the platelets are activated by any means, exposure to collagen, the most common, and we could even put this in a test tube. If we would take blood out of you and put it into a generic test tube, to some extent the blood would clot. One of the reasons those vacutainers are very specific, the ones that you see with all those different color top tubes when you see blood being taken out in the lab. Extrinsic, because factors need for clotting are not within the bloodstream, and we call it now tissue factor. It used to be called tissue thromboplastin, but tissue factor or factor 3 is sufficient. Okay, and again, that comes from damaged tissue, whether it's just a cut or a scrape, or whether we're talking about a gunshot wound, a stab wound, an explosion, whatever. And because it bypasses the intrinsic steps, it's faster. So this is it in a nutshell. Did you have to memorize this? Absolutely not. To have an idea how it works, couple of things noteworthy. You're going to see calcium, calcium, calcium all over the place. Calcium is a big, remember I told you about, we underscore, AP2 underscores the importance of calcium. So you'll see it with regard to the heart. You're going to see it with regard to the clotting cascade. You're going to see it with regard to kidney function. Calcium is a big player. Things like, again, those positively charged particles like calcium, sodium, and potassium, we get all excited when things are going wrong with them, particularly calcium and potassium. Okay. So here's the intrinsic pathway, a blood vessel. Not so much ruptures, just damage. Okay? Exposing the underlying collagen. And so all of a sudden, this goes from inactive factor 12, just listen to it, to active. That activates factor 11, activates it. That activates factor 9 with calcium. 9 activates 8, then 8, it looks like 9 and 8, the active, then complex, and magically they make 10. And then voila, eventually you get this prothrombin activator. Okay, bunch of steps. 9 and 8 are important players because when we have genetic defects or problems with them, that's where we hear about very famous bleeding disorders. The most famous involves a factor 8 deficiency, and it's called hemophilia. And for years, we did not have any way to treat that. Of historical importance. Versus the extrinsic pathway, a damage. So you can see they're pointing out this is just like a little defect. This is torn, if you want to look at the illustration. So it releases tissue factor in the presence of calcium magically, okay, This activates 7A. You could use it in the intrinsic pathway or bring it right down here with the tissue factor, and voila, we're at factor 10 and activated. Short, a couple of steps, bang, bunch of steps. Faster, less frequent, slower, happens all the time. Just part of our ongoing maintenance procedures in your bloodstream. There's a big such as men at work, women at work. Anybody at work? Sure, nobody cares. At least I get to go home and there's somebody who loves me. And if the dog's not there, even my wife occasionally likes me. The cat sleeps with me. One of the cats sleeps with me until she comes home. Then it's magic. Oh, mom's home. Forget it. Fair weather friend. So here's what happens effectively. That's the idea. We're going, the whole ball game is to activate, and I'll go back and show it to you again. This whole idea is to create this prothrombin activator that consists of factor 10 and factor 5 and calcium and whatever else is in there. And that's going to change prothrombin to thrombin. It's going to activate the thrombin, and that's going to then lead to fibrinogen, as I've written on the board, becoming fibrin. The fibrin strands form the substantial basis for a clot. Okay, the plasma is trapped. You're going to see the illustration. Gel-like, catching the formed elements, stabilized with calcium, activating something called factor 13. Interestingly, the fact that we're activating factor 13 is very important, because once you particularly think of a blood vessel that's doing maintenance and forms a clot, I mean, the maintenance is continuous all over those blood vessels. If you didn't have something to get rid of those clots once they form, the clots would theoretically be there forever. Not the case. So you're going to see that factor 13 activates the pathway to get rid of clots. Okay, that's the beauty of your body. We're forming something. Once it's done its job, how do we get rid of it? I mean, if it's debris, we can send a macrophage out to gobble it up. If it's a blood clot, we have to somehow break it apart before something can come along and gobble up the debris. So it's a mechanism within a mechanism. We have one to build it and one to break it apart. Quick thinking. Casino, maybe this weekend? Nah. Never asked for those kind of favors. So cross-links the fibrin, strengthens. Anticoagulants, okay, basically factors that normally dominate the blood to inhibit coagulation. We have those inherently there. That's all those deactivated factors or precursor factors. So here you are, fibrinogen dissolved in the plasma versus fibrin, which is not. And then even that factor 13, as we activate it with our buddy calcium, forms this mesh. Look at that. Fishnet, red blood cells. Traps like that, begins to form a gel. Eventually it tightens and firms up. One of the best illustrations, an actual micrograph of what's actually happening in a clot. Imagine that. So, I mean, you're already setting a trap, biological trap, almost identical to a mechanism we use commercially in real life. I mean, to me, it's remarkable. And it's certainly, I think dramatic evidence about, the brilliant way molecules mimic so many things inside of us. And they give you all the names and where they're formed. And you don't have to know any of that stuff, et cetera, et cetera, et cetera. Most of them are from the liver, as you can see. That tissue factor comes from cell damage. Calcium is basically in the plasma and the liquid component of the bloodstream. Everything else pretty much is from your liver. So again, think of somebody with a liver disease like hepatitis, or somebody with cirrhosis of the liver. It's just more attendant problems. People with liver disease are in big trouble. They can't make proteins like albumin. They can't make globulins. They can't make antibodies. They can't clot. And I mean, and all of that means one thing: if they get sick, they're not going to do very well. So clots are stabilized and removed when the damage has been repaired. Our friends, actin and myosin and the platelets contract. And what they do is they pull that mesh and they squeeze the serum. What's serum? Serum is plasma minus the fibrinogen. Once those fibrin strands have formed, once the fibrinogen has been activated and the strands form, they're no longer in the solution. They're insoluble. That's the definition of serum. Years ago, you might remember me saying we used to do serum blood glucose. Now we serum glucose. Now we do blood glucose. It was an unnecessary step to take the clotting factors out in the laboratory. So serum is plasma minus all those clotting factors. And what is it doing? The actin and myosin, just like they create muscle movement, they're creating clot movement and sort of squeezing the liquid out. We can use the liquid elsewhere, but we're stabilizing the clot. Now, the vessel is healing even as the clot forms. This is what I talked about before. PDGF, platelet-derived growth factor, stimulates division of smooth muscle in cell walls and in fibroblasts. Connective tissue, the parent cell, go back to AP1. You remember, they all come from a common ancestor, that mesenchymal cell. Fibroblasts, chondroblasts, osteoblasts, and they can kind of flip-flop between one another. Remember, a bone's healing, it starts fibrous, then it becomes cartilaginous. You get that fibrocartilaginous sort of blob that firms up and eventually becomes bone. That's why we use platelet-derived growth factor in wound healing. It's going to generate, effectively, it's going to generate the foundation for that wound to heal, if you want to think of it that way. So there's also something called vascular endothelial growth factor, stimulating the endothelial cells to multiply and restore the lining. So we take these factors, we don't are they analyzed chemically to some extent, but we're able to extract them, and that really created an additional realm of medicine called wound healing. And I told you, I was working with people who were in the early stages of this, understanding and dealing with ulcerations in sickle cell patients, interestingly enough. Where one of my mentors was dealing with his clinic down in Richmond, Virginia. And I'd go there a couple of days a week and treat these patients. Fascinating. I learned more in 8 weeks in the summer than you probably could learn in 2 years clinically some places. So what happened? How do we get fibrinolysis, or however you want to pronounce it, removing after the repair is completed? Again, if they're there, sooner or later they're going to get in the way. And clots in blood vessels, if they're not healing, they're in the way. They're obstructing blood flow, and they're going to create more clotting problems. So therefore, within a couple of days, begins with 2 days and continues for several days until the clot is dissolved. Plasminogen, another protein, is in the clot. It's another one that's in your bloodstream. And this one, just like fibrinogen becoming fibrin, we want to make plasminogen into plasmin. To do this, something is generated called tissue plasminogen activator, and along with factor 12 and thrombin all play a role. So the name, and it's an acronym, you need to remember, it's called TPA. Years ago, think of it this way. If someone forms a clot in a small blood vessel going to their heart or to their brain, what those are going to eventually cause is a heart attack and a stroke. Years ago, we would take an extract of a poison from Streptococcus, little strep throat strep. You'll learn about it in micro, called Streptococcus pyogenes. One of the things that Streptococcus does that you'll learn about in micro, at least with me, is it causes things to spread. It causes infections to spread because it has enzymes that break apart tissue. They used to take it from streptococcus, inject it. If you got to it in time, you'd prevent that heart attack or stroke from actually occurring. Trouble was, there's a certain amount of problems that it could damage other stuff. We now make this activator, which is a polypeptide, not unlike oxytocin or pitocin, not unlike antidiuretic hormone. Okay, we make it in the laboratory, and hospitals have this on hand in emergency rooms. So if they get somebody who has had was obviously a very recent stroke or a very recent heart attack, before the damage becomes permanent, there is a window of opportunity before the tissue dies. And then inserting a catheter into that person, typically you go through the groin by way of the femoral artery. You can insert that, or sometimes you might have to go in the neck if you're going to the brain. You're able to inject this TPA, which is biologically compatible, like the streptococcal stuff. Okay, and it will be a clot buster. My aunt had that done. I mean, she lived like a lot of older folks. She retired in Florida. She's died within the last, I'd say, 5 years, into her early 90s. I think when she was in her late 80s, they had, fortunately, whatever retirement community she was living with, when they got her to the hospital, all they have is a bunch of retirees and elderly people. And someone's going to some of those places. They identified it and were able to, prolong her life without, and not have that incident really do significant damage. She survived a number of years after. And there's nothing unusual about that. Okay. Depending on the area where you are, hospitals are designed to service certain communities that they know. So they're going to have equipment and medicines. Some won't have them all, but if you have a predominance of older people, you deal with older people problems. If you get a predominance of children, you have child problems, etc. You get the idea. So swift removal of clotting factors is important, inhibiting them so we don't get overclotting. So there's a variety of things that combat it, like antithrombin. Heparin is a chemical many of you will use. When you'll start an IV, and just to have the line open. So when I went for a procedure the Tuesday before we started class, the Tuesday right after we started class, I had another endoscopic procedure, routine. So, but they sedate you. And so what they did, boom, they put what's called a heparin lock. The nurse came in, he inserted the IV here, basically flushed it with some heparin, put a cap on it. And so it was just sitting there ready to use. And when they got me into the procedure room, then they inserted the IV, and then they gave me the medication to sedate me. So there's nothing unusual about that. So we make heparin. It's in those mast cells. Those blue granules have heparin and histamine in most of those cells that are there. So heparin is something that's used a lot to combat. We treat a lot of in-hospital patients with blood clots with heparin. It has to be used by injection, not just directly into a vein, but you could inject it elsewise. When we send people home, we use other medications. But again, you have to monitor those. So again, the smooth lining prevents platelets from clinging. There's nitric oxide. Vitamin E is a very potent anticoagulant. A lot of folks take vitamin E supplements. They'll take, again, the fat-soluble vitamins are A, D, E, and K. Vitamin E, we think, combats those toxic derivatives of oxygen. For years, it was really something that was almost routinely utilized by folks as they got older. You will find, for many of you going into the areas where you're going to be working with pre-op patients, pre-op orders are standard because you're going to be giving them to them. Oh, we've got you scheduled for a procedure. You're on a phone doing an intake or make sure you're not to take any of this. What do you take daily? What vitamins? And if they come up with vitamin E, oh no, 2 weeks before you have to stop them. Because it can make clotting a big problem. I know you're tired of hearing me say this. I am giving you absolute pure gold. You will impress those nursing instructors the minute they talk about, well, we're going to be talking about how you interact with pre-op patients. vitamin E thing's going to get you brownie points, and you do not have to give me the credit. Give it. You should come back. Okay. Magically, a latte should appear on my desk. Thank you. You made me look good. In lieu of that, there's always. I'll send you my. No. None of you are writing this information down. Here. So when we talk about clotting diseases, we call thromboembolic diseases. Thromboembolic disorders, undesirable clotting, or bleeding disorders, other way around. So there's a lot. And this one is very rare, but can happen. It's called DIC, disseminated intravascular coagulation. It involves both clotting and not clotting. You see this because you all have had gram negatives in micro, whether you had me or not. Okay, gram negatives produce toxins if they get into your bloodstream, if they get in like a burst appendix. One of the complications of what we call gram negative sepsis can be this. Okay, and what it does is it gobbles up the clotting factors. But when someone gets DIC, they're in big trouble. Let me tell you, big trouble. So thrombi and emboli, by definition, a thrombus is a clot. When it breaks off, it's no longer a thrombus. It's called an embolus. And normally the whole clot doesn't break off, but just a portion of it. That is also an embolus. So whether it's a clot that forms or something that breaks off and clots somewhere else, basically they're the same kind of a thing. So that's why we call it a thromboembolic disorder. Definitionally, the clot is a thrombus. If it breaks off and travels, it's an embolus. That's all. Okay, and this is what happened. Embolus freely floats, embolism, that process, it can go to the lungs. Most famously, patients in bed for a long period of time, while we get them up, while we get them walking that day or the next day, all the time. We don't want them in bed because if they're in bed like this for long periods of time, back here in the calves and the upper thigh, you have lots of areas where blood will be sluggish and stay. Okay, we call that stasis or staying phenomena. And that's when they form clots. Those clots break off. And if they do, they will travel. The next stop, all the blood vessels get bigger. When they start to get small again, when you get to the lung. So they can block the lung and cause immediate death. It's called a pulmonary embolism. Pulmonary for lung, embolism, a clot that's traveled typically from your leg, anywhere else. Yes, ma'am. The squeezers. Great point. Everybody heard that? This happened to me. I was hospitalized twice for more than 7 to 10 days post-op after ulcer surgery. And so what they do when you're in bed for a long period of time, plus they did it for me pre-operatively, I was in to get healthy enough for him to operate. Another story. They put TED hose, thromboembolic disease hose, which are like support hose, on, and then they put inflatable things, and they sequential. So they're compressors. They're sequential compressors. So squeeze for 20 seconds, release, squeeze for 20 seconds, release. Sometimes we'll gauge them both the same or alternate them differently. And they'll run those X amount of times during the day for people who just aren't able to get out of bed. I probably for the first 3 to 5 days really couldn't get out of bed. And that happened on both occasions. So I jokingly, you can buy those, by the way, not to quite the same, but I mean, because I have a leg that swells up. We have those at home. I like to think of hugging the leg. Thank you. So all of these types of things. So the immobility is probably the major. What stops clotting? Here's one, aspirin. For many years, I do not know if we still use it as extensively, when someone had open heart surgery and they did bypasses. They don't do them as frequently as they used to. The post-operative treatment was a baby aspirin a day. That is a sufficient amount at that point in time to stop that problem, okay? It's basically an antiprostaglandin, okay? And as you can see, it lowers the heart attack incidence significantly. Aspirin is a very good anticoagulant. That's the good news. The bad news is for people, you use it excessively, it can then impede the ability of the blood to clot when it needs to. Clotting's part of what has to happen all the time. Heparin, okay? This is typically associated inpatient, okay, when there's a greater degree of risk. Those IV locks, if we're not using them, we flush them out with heparin because little bits of blood will clog in there and we'll flush them out. You'll take some heparin dissolved in saline, you'll push it in, you pull it out, and that's the way to open one of those heparin locks so you don't have to keep putting in new IVs like that because it hurts. It doesn't hurt you, you're putting them in. It hurts the patient you're putting them in. And this for years, we don't use it as much because you have to monitor them all the time. Warfarin products, most famously called Coumadin, Coumadin, are orally effective, and not just atrial fib, but lots of different problems. These directly interfere with vitamin K dependent clotting factors. They work well. The trouble is you have to monitor, you have to do blood levels typically every other day to make sure you're in the right range. And what we do is we do tests. You're going to hear about it. It's called INR. It's an international ratio. And what we do is we study control values and patient values to determine how effective the clotting is. We want to reduce the clotting time by a factor of about 50%. So if it takes 12 seconds, it should be 18, something like that. The nursing folks are going to teach that. But if you work particularly in long-term care, you're always, any patients who are on this, you have to monitor. Nowadays, we use agents that have less side effects and are easier to monitor. What they do, for lack of a better way to express it, they make the red cells in the platelets more slippery. So you can sort of slide and bend past each other. Okay. Those medicines were in their infancy when I was studying pharmacology 50 years ago. Now they are a lot safer and they do not have as many side effects. So, pharmaceutical science plays a role. These are something that you will see. Okay. Sometimes people do not have enough. Thrombocytes is another name for a platelet. Penia means not enough. So when you have thrombocytopenia, okay, you end up with, unfortunately, blood that doesn't clot. Typically, you see it manifests itself. You see it under the skin or on the skin. And so they get petechiae or tiny hemorrhages that we see there. Yes, you could have it because people are undergoing chemotherapy or radiation therapy. You can look at the platelet count. If you go back and look at mine, it was like 173,000. Generally, from 150 to 400,000 platelets per microliter is fine. When you get under that number, watch out. We can, like I said, we can spin down and transfuse platelets. That's all done. Petechiae are little, they almost look like tiny little freckles. Okay. When they get larger, we call them purpura. Pura. A lot of times we'll see that almost with certain people have allergic reactions. Somebody recently showed me, did you show it to me, John? That purpura, somebody did. I'm trying to remember who showed it to me. Somebody showed me a picture of a relative that had on their skin. It's called Henoch-Schoenlein's purpura. It's an allergic phenomenon. It's an easy diagnosis if you're seeing it. If I've seen it, you'll see it. Understand, everybody. If I saw it on a regular, have seen something on a regular basis over my 25 plus years of seeing patients, you're going to see it. Because most of us see the same things all the time. So that, I'm trying to remember who showed it to me. Oh, I don't know. Who comes to me? Voila. That's what it looks like. Little freckles, except when they get like bigger and blotches, that's purpura. It's like tiny, you and I all know what a blister is. If it's little, we call it a vesicle. If it's bigger, we call it a blister. And if it's like a giant blister, we call it a bulla, Bulla. And if it's the blister of all blisters, we call it a bleb. Okay, I love the names. my fascination with language. Most of the time it's related to liver problems because that's where you make the clotting factors. Vitamin K deficiency, liver disease for producing bile, which is needed to absorb fat and vitamin K. If there's nothing else, the heart of this presentation is be kind to your liver will be good to you. One of the big problems with it's one of the few things that you can garner from your BMI, that even though we don't pay as much attention, that metabolic index number, that overweight versus over fat, that's like the percentage of fat your body is. The fattier your liver is, the less likely it works as well as it should. So be watchful of that, everybody, please. And here, from bleeding disorders, hemophilia A. We used to have no treatment. This was the one, if you remember historically, the Russian Revolution, Rasputin, the future Tsar screaming in pain. Am I ringing a bell? Rasputin. Thank gosh. I'm going to assign history and readings for you guys. Help me. History didn't start 10 years ago. Okay, so hemophilia A, that was the one that affected them. B and C, I will give it. You're all getting ready. It's the weekend. I'll see if there's anything relevant here before we do the blood typing thing. Goodbye. Thank you. What am I going to do with you people? Goodness.